In this section, we're going to discuss how these fluids get regulated. In our bodies, all the time, there's this ongoing maintenance of balance between these compartments. You've heard this referred to in the past as homeostasis. That is where what we're going to investigate, what happens to maintain balance between these compartments in the human body. There are three major regulatory mechanisms for handling water management in the body. The first is vasopressin. You will hear this referred to as AVP. You will hear it also referred to as DDAVP in the hospital. You'll also hear it referred to as antidiuretic hormone, or ADH. For this lecture, I need you to be familiar with the term vasopressin, AVP, antidiuretic hormone, and ADH. I will use those interchangeably. Vasopressin and antidiuretic hormone is secreted by the hypothalamus. The hypothalamus has osmoreceptors. This is a new term. It's basically a combination of some terms we've mentioned already. We've talked about receptors. Receptors are basically sensors in the body that respond to either a change in state or a chemical in the body, an endogenous chemical or an exogenous chemical, something we've given or something we have within ourselves. Two great examples, think about endorphins. You've heard of endorphins. Those are endogenous chemicals that act on receptors. And then morphine is an exogenous. It's something we administer, acts on the same receptors. Osmoreceptors are not drug dependent. Osmoreceptors, as the beginning of the name implies, respond to changes in osmotic pressure. Remember, in the previous lecture, we talked about the normal range of osmolarity in the human body. Osmoreceptors constantly monitor the osmolar state of the body. And based on the vessels and tissues osmolarity, it sends signals to the brain and subsequently to the hypothalamus to tell the hypothalamus either to secrete vasopressin or not secrete vasopressin. It is important to understand when vasopressin or antidiuretic hormone is in the body, what does it do? This is an important understanding to have, not just for now. This will come back in the endocrine lecture later in this semester. Antidiuretic hormone. We have to break that down to understand its meaning and to understand its action. To break it down. So, a hormone is a chemical that the body produces to regulate things. All right, that part's pretty straightforward. Let's talk about diuretic for a moment. Okay, marker didn't work. Let's talk about diuretic. Not antidiuretic, just diuretic. So if we are talking about diuresis, what do we mean by that? What we mean is make urine. You are familiar with diuretics like Lasix, like hydrochlorothiazide, spironolactone. When you give those drugs to people, what does it do? It makes them pee. So, diuretics make urine. If we have a hormone that basically is going to function like a drug, that we secrete into the human body that is going to impact urine production and is called anti-diuretic hormone. Remember, anti basically means not. So this hormone is going to cause the body to not make urine. Anti-diuretic hormone. So as ADH, AVP goes up, urine output goes down. So more antidiuretic hormone, less urine. So if the body is fluid overloaded, then that person is going to have less antidiuretic hormone, which means they'll pee. If a person is dehydrated, they need to hold on to their fluid. Antidiuretic hormone is going to be secreted to make them not pee. Depends on the state of the body, the effect that is going to have may had upon the hypothalamus as a result of the osmoreceptors. So when someone gets dehydrated, fluid in the plasma goes down. The osmoreceptors go, oh, our osmolarity is up because the fluid is down. If the fluid is down, there's more stuff floating around in the solution, so osmolarity goes up. If someone's dehydrated, their osmolarity is over 300. The osmoreceptors recognize this signal. Oh, our osmolarity is 340. We need to hang on to some fluid. We need to not pee. So we're going to release antidiuretic hormone, which is going to tell the kidneys to not let urine out, which is going to be retaining fluid, which is going to help balance the osmolarity. And the opposite is true with patients who are fluid overloaded. Another regulatory mechanism is thirst. Thirst is also generated from the hypothalamus and stimulates us to drink water. So if as you're working out in the sun in this heat, well, it's hot right now. I'm recording this in the summer. You're mowing the yard. It's 104 degrees. You're sweating a lot. And before you get to dehydration, your mind says, I'm thirsty. I need a drink of water. So you go drink water to replace the fluid you're losing through sweat. That is the thirst response. The thirst response is a late response to fluid levels and is not exquisitely sensitive to fluid states. There are other things that can affect thirst, but it is another regulatory mechanism. The third regulatory mechanism is water transport, and by this I'm referring to the removal or shifting of fluids by the kidney, and the glomerulus specifically. The glomerulus is that functional part of the kidney where sodium gets retained or excreted, and in the loop of Henle where fluid gets retained or excreted. So the glomerulus, in response to antidiuretic hormone, will then retain sodium and excrete water. This is what we mean by water transport: either retain sodium, excrete sodium, retain fluid, or excrete fluid. Also, the renin-aldosterone-angiotensin pathway contributes not only to the retention of sodium in water, but also to arterial venous constriction. If someone loses fluid, there's less liquid in the tube. In order to maintain sufficient blood pressure so that you stay conscious while you're mowing the yard, the arteries and vessels have to constrict to maintain an appropriate blood pressure, to maintain perfusion to heart, lungs, brain. That keeps you conscious and keeps you moving. So we have to do two things. We have to manage fluid, and we also have to manage the vasculature. Those are the three major regulatory mechanisms for fluid management in the body. Oops. Now, there are additional regulatory mechanisms that are occurring concurrent with these three majors. The lungs, as a outflow or a downstream effect of the renin-aldosterone angiotensin pathway, produce angiotensin II, which causes arterial venous constriction. In the case of fluid overload, angiotensin II is not released, and so vessels can dilate to accommodate the extra fluid. Stretch receptors are receptors in the major vessels of the body, the atria and the ventricles primarily, and then also the aorta. These receptors sense the amount of stretch on the tissues of the heart. So if someone becomes fluid overloaded, this extra fluid is going to tend to be retained in the atria. The ventricles are going to contract and eject fluid. Extra fluid is going to tend to be backed up into the atria because they're lower pressure chambers and their force of contraction is not as forceful as the ventricles. So the atria then stretch as a result of the extra fluid. That stretch then causes the secretion of atrial natriuretic peptide. This is a compensatory mechanism to try to affect the diameter of the vessels to accommodate this extra fluid. The same is true for B-type natriuretic peptide, which is secreted as a result of the stretch receptors in the ventricles sensing the extra volume. So as more stroke volume comes into the ventricle, it's distended. That distension signals the stretch receptors to try to improve perfusion to the kidneys and help eliminate this extra fluid. Baroreceptors are sensors in the carotid sinuses up around the brain, in the carotid bodies around the neck, going toward the brain, that sense distension in those areas and send signals to the body to respond and address either a lack of fluid or a need to manage this extra fluid. A good example of your stretch receptors kicking in is when your blood pressure gets low. Your stretch receptors send a signal that causes your blood pressure to drop, that causes you to pass out. When you pass out, that causes blood flow to distribute equally among a body that's laying flat. If you're laying supine on the ground and your body can equally distribute fluid, then you will have an increased blood flow to the brain. The carotid sinuses will accommodate that, and your blood pressure to your brain will improve and you will wake up. So it's a normal response to syncope. The adrenal glands also participate as a result of this renin-aldosterone angiotensin pathway. The adrenal glands are signaled by fluid state to either secrete or not secrete aldosterone, which then produces water retention. And as I mentioned earlier, the thirst response will cause us to drink more water. So the main mechanism, the main functional portion of regulation is cardiac output. In order for the kidneys to get fluid to them to either eliminate it or retain it in order for the osmotic receptors on the hypothalamus to receive the signal, the stretch receptors, baroreceptors, all of these different portions of the body to receive the signals as a result of pressure and fluid states. There has to be a cardiac output. There has to be a squeeze of the heart to push the fluid into the vascular space in order for the signals to be picked up. So cardiac output is our key element of regulation. Basically, the cardiac output can be broken down into heart rate and stroke volume. The simplest equation for cardiac output is this, and is something to memorize. Cardiac output equals heart rate times stroke volume. Stroke volume is the amount of volume that's ejected from the heart with each squeeze. Cardiac output is so many liters per minute. Stroke volume provides you the liters. The beats per minute, your heart rate, provides you the stroke volume per minute. So if you take the stroke volume, liters, and multiply that by heart rate, now you have cardiac output, a liters per minute. Heart rate is essentially force and frequency. So it has to do with how often the heart is squeezing and how forcefully the heart is squeezing. If someone has a nice, strong, young, healthy heart, when it contracts, you get a full contraction of the heart muscle and you get ejection of 2/3 of the stroke volume. That's normal. You get ejection of the stroke volume, 2/3 of the stroke, 2/3 of the volume of the heart, which 2/3 is the stroke volume. That's the force. How often that happens is the beats per minute. So that's regulated by the nerves in the heart themselves and hormones that act upon the heart. Stroke volume is determined by blood volume and then also resistance that the vessels and structures meet as a result of the forward movement of fluid. So here is an example of the three key elements of cardiac output, heart rate, and stroke volume. Preload is the volume. Preload, volume. Make those two connections. Preload is the volume going into the heart before contraction. So this can be thought of as stroke volume. It can be thought of as the fluid in the atriums. It's basically the fluid state of the patient. Resistance or afterload is the resistance that the heart meets when it contracts. So you can see the arrows representing preload are the blue arrows. Think of fluid here. The blue arrows going into the heart, and I'm depicting the right atrium and right ventricle, but the same is true of the left atrium and left ventricle. The left atrium and left ventricle have a preload. Then the left atrium and left ventricles contract and eject blood. That's this yellow arrow with the blue line, is the blood moving out into the aorta. As the blood moves into the aorta, it encounters resistance. Resistance is the tone of the arteries as the blood is ejected out of the ventricle. That's resistance. The force that it takes to overcome this resistance is contractility. So both the right side and left side of the heart have preload. Both the right and left side of the heart have afterload, and both the right and left side of the heart have contractility. Those three components, preload, afterload, and contractility, form the essence of cardiac output, determine how well cardiac output operates. So remember that. Heart rate times stroke volume equals cardiac output. Cardiac output is composed of preload, afterload, and contractility, volume, resistance, and squeeze. So Through a normal day, there's a normal amount of fluid losses that happens as a result of normal biologic functions. That's represented on this slide. What I want you to key in on is the biggest determinant of fluid volume state is the kidneys and the process of urination. Double down on that. Kidneys and urination. This is why for the remainder of the semester, you're going to hear from me over and over again questions about BUN, creatinine, potassium as it relates to kidney function. Kidney function is a key determinant in managing your overall patient outcome, regardless of the condition. If a patient comes in with normal kidneys, that's fine. We want to know that, and we're happy about that. But we're going to watch it. Things can change during a hospitalization, during an illness as a result of tests. We'll talk about that more as the semester goes on. But this is why 1,500 milliliters a day is the biggest chunk of fluid loss or gain in the human body in a day. The skin is next, and then also the lungs, and these are called insensible losses. We know we lose liquid through the skin, but you can't always tell it. Here in Arkansas in the summer, most of the time you can because it's so humid, so you sweat. On a day that's very dry or arid, if you go to Arizona, you may lose 500 or more milliliters of fluid a day and not have any awareness of it because it's so arid. The lungs is definitely an insensible loss because we just aren't aware that we evaporate 300 milliliters of fluid through the lungs just in the process of breathing. Feces have approximately 200 mils of fluid a day in its makeup composition. In total, that's about 2.5 liters a day that are lost in fluid. If you're exercising, even if you're exercising aggressively, you're probably only losing about 3 milliliters a day. So that just gives you an idea of where the fluids and where they're managed with the different organ systems in our body. This slide is from your book, and I encourage you to become very familiar with it. I have already referenced the renin-aldosterone angiotensin 2 pathway. You need to be very familiar with that pathway for the remainder of this course. It will come back over and over again. We're talking about it now with fluid states. We'll talk about it with electrolytes. We'll talk about it with lungs when we discuss the pulmonary system, and we'll also talk about it in endocrine. So become very aware. There will be test questions related to renin, aldosterone, angiotensin, and angiotensin 2. Be familiar with this slide. Now, when we're assessing patients with fluid volume changes, in the next portion of the course, we'll be in the classroom and we'll go over a variety of case study type situations and different conditions. The important thing as you're assessing your patients, you've been working on assessments, is notice what it is you're noticing. So some things you're going to see and may not remember to call your own attention to are things like skin color, temperature, texture, turgor, moisture. Are they diaphoretic? Are they clammy feeling? Is the skin cold? Is the skin warm? Are they flush? Are they pale? What do the mucous membranes look like? Are they nice and pink, or do they look pale? Are they purplish? Mentation, do they seem clear? Do they seem mostly clear, but then they're kind of hedging their answers on some questions? Those are great things to tune in on. What do their lungs sound like? Lungs are clear? That's normal, yes, but that's a finding. Remember, normals are also findings as a part of your assessment. So can you see hand veins or neck veins? That's a finding. Are they bulging and distended? Do they look normal? Can you not see them? But clear lungs, normal hand veins, those are all findings. We focus in on crackles or rhonchi or wheezes. Those are telling as well, they're assessment findings. But remember, your normals are also findings as well. Edema, the presence or absence of. So if there's no edema, that tells you something. That tells you where to start looking in the absence of edema for other problems that you might be anticipating. Blood pressure. Blood pressure, obviously, if it's abnormal, is a key assessment finding. And blood pressure, if it's normal, can be. However, a normal blood pressure doesn't mean your patient doesn't have problems. They may be compensating in some way. So that is an important thing to tune into. What's their blood pressure, and what does their blood pressure look like in the context of this physical body? How's the body responding with that blood pressure? And then last but not least, lab values. What are the lab values telling you? Labs such as BUN, creatinine, electrolytes. And we'll get into the electrolyte normals in the next section, the next unit. But those are all indicators that point to your overall assessment. They're all part of your assessment. Here are your lab ranges. So earlier I mentioned a serum osmolarity of 285 to 295. This slide needs to be updated to that, so you can disregard the 275 to 290 here. It should be 285 to 295. Urine specific gravity, 1.010 to 1.025. These two tests are specific tests for osmolarity in the human body. The other tests are indicators of osmolarity, yet they can be affected by other conditions in the human experience. So while they may be elevated, for example, BUN creatinine could be elevated. Your patient may not be dehydrated. Your patient may have kidney failure. That's just a simple example. Potassium, the normal is 3.5 to 5, and sodium 1.35 to 135 to 145. These are the normal value ranges I want you to know for this portion of the course. In the first section, there will be questions related to normal sodium levels and normal potassium levels. You need to recognize that abnormal sodium levels can be an indication of someone being dehydrated or fluid overloaded. We'll talk about that more as we get into class. The next section will be clinical situations and presentations, and we will do this portion in the classroom. See you then.